everyone is here, so I'll make a start. I'm very excited to welcome you all today to our weekly ID meeting. Nali and I have been planning this for some time and very excited to present a case of a sort of very difficult Mycobacterium ulcerans in an immune-compromised host. So Nalian will present the case as our current fellow. We also have Violet Zhu, who is a specialist pharmacist who will provide some updates and information about some of the really tricky drug interactions that we have. And we are very, very honoured to have special expert commentary by Steve Mui and Dan O'Brien, who have a wealth of knowledge about this organism, which is somewhat unique to us here in Melbourne or Victoria. So this is a very unique and striking case that I've been looking after for some time about Mycobacterium ulcerans, and hopefully it provides some real educational highlights. And for a lot of our overseas fellows from Spain or Malaysia, this will be pretty interesting. You may not have seen something like this before. So without further ado, I will get Nalian to present the case, and this is a really interactive session, so please pop any questions either in the chat or put your hand up or just interrupt. That's fine. So thank you.
Thanks, Michelle. I'll just share our slides.
Technical difficulties, are we?
It should be loading now.
Yes.
Is that all right? Yeah. Yeah, as Michelle said, this was a very interesting case, and I've called it graft versus Mycobacterium ulcerans, and I think you'll see why fairly soon. So this was the case of a 63-year-old gentleman from home with his family in northwestern metropolitan Melbourne. He had a history of follicular lymphoma for which he'd had treatment initially with R-CHOP, but then and then maintenance rituximab, but then developed therapy-related MDS, for which he needed an allogeneic stem cell transplant in 2021. And then, unfortunately, it was in remission for a while, but he had a relapse and actually developed therapy-related AML. So he required a second allogeneic stem cell transplant. That is in remission as per his 1-year bone marrow biopsy, but complicated by significant oral, skin and liver graft versus host disease, for which he was receiving treatment with ruxolitinib at 5 milligrams twice daily and prednisolone 5 milligrams once daily. As I said, he was living at home with his family, had quite a number of pets at home, so a dog, 2 cats, 2 rabbits, multiple birds, a chicken and a fish, possums in the garden that they'd sort of seen around but certainly not in contact with, and no known animal bites, no recent travel history. So in September of 2024, so this was about 16 months after his stem cell transplant, he developed this atraumatic left lower leg ulcer, which you can see in the picture here. It initially started off as just a small ulcer and over time grew to 10 to 12 centimetres in diameter. A punch biopsy showed ulcerated skin and subcutis with a thick fibrinous crust on the surface, including incidental colonies of bacteria. There were no granulomas, but there was fat necrosis in the small amount of attached subcutis, and there were abundant Wade-5 positive bacteria seen in the deep portion of the biopsy, consistent with atypical mycobacteria. No fungal elements were detected, and M. ulcerans was detected on both tissue and swab PCR. AFB smear was negative and culture negative on that initial biopsy sample. There was also MSSA isolated on a swab. The swab taken a couple of weeks later was also smear negative, but M. ulcerans did end up being cultured at 9 weeks. So The reason why this case was so striking is really, I think, encapsulated by these images. So on the left is kind of a few weeks into treatment, and then this is the progress of his wound over the next 3 months. So that last photo was the last time we saw him in clinic on the 10th of February when he actually stopped his treatment. I'll go into the progress a little bit later, but as you can see, this was very much out of keeping with sort of what we would expect to see with Mycobacterium ulcerans, a really significant skin damage and quite distal to where the original ulcer was. So just a little bit about some background on Mycobacterium ulcerans. So proximity to aquatic habitats, particularly activities within stagnant or slow-flowing water, is a common risk factor. And the bacteria can be inoculated by insect vectors or from environmental reservoirs if there's skin trauma. In Australia, there's a complex interaction involving mosquitoes, native possums, mainly ringtail possums, and the environment, which influence risk of acquisition of M. ulcerans. And human-to-human transmission is considered unlikely. M. ulcerans grows optimally at around 30 degrees and actually quite poorly at 37 degrees and above. So it may explain why this organism shows a skin tropism and actually limited systemic dissemination. And it is a slow-growing mycobacterium. So in our patient's case, the cultures became positive at 9 weeks. The graphic on the right is from a paper by Arvin Yeramili from a couple of years ago, which I think demonstrated nicely sort of a distribution map of where the ulcers tend to occur. And the mean incubation period is about 4.5 months. And transmission usually occurs during the warmer months, but because of that long incubation period, disease actually peaks in winter. So some of these graphics are from Steve and Dan's recent guidelines and a lot of the information as well, so thank you. The graph at the top there is the disease incidence of Buruli ulcer in Victoria, and you can see it was made notifiable in Victoria in 2004, and we've really seen an uptick in cases probably since kind of 2015, 2016, and there seem to be sort of areas, particularly on the Bellarine Peninsula and also along parts of the Mornington Peninsula, which are kind of hotspots for Buruli ulcer. This patient isn't a resident of one of those areas, but sort of not far from where they have occurred. So diagnosis is the recommended sort of pathway to diagnosis is PCR directly from the ulcer. And when the swab's taken, it should kind of circle the undermined edge of the ulcer. And false negatives, though, are not uncommon with a PCR test. So the alternative is a skin biopsy from the centre of the non-ulcerated lesions or from the margin of ulcerated lesions. Culture is less sensitive than PCR and, as mentioned, can take a long time to become positive, so up to 12 weeks. Histopathology tends to show necrosis of subcutaneous tissues and dermal collagen accompanied by minimal inflammation, and acid-fast bacilli are considered the most reliable histopathological features for the diagnosis of Buruli ulcer. Epidermal hyperplasia and chronic inflammation with formation of granulomas is more frequent in ulcers compared with pre-ulcerative lesions. So interestingly, M. ulcerans actually shares a common ancestor with Mycobacterium marinum, but it differs in that it somewhere along the line acquired a virulence plasmid called this P-mum plasmid. This encodes enzymes required for the synthesis of macrolide toxin called mycolactone, which has cytotoxic, immunosuppressive, and analgesic activity. So it's developed a mechanism to subvert the innate immune system. It can actually establish residence inside host macrophages and use host granulomas for expansion and dissemination during the initial phases of infection. In advanced lesions, extracellular clusters of M. ulcerans reside in necrotic subcutaneous tissue and are actually protected from infiltrating leukocytes by the cytotoxic activity of mycolactone. So I think it's helpful to kind of parallel the immune response to Buruli ulcer to what happens in skin GVHD to think about what we observed with this patient. So upon sort of the initial recognition of M. ulcerans through a number of receptors, the keratinocytes produce bactericidal reactive oxygen species and a lot of chemokines and chemoattractant proteins. Once mycolactone producing strains of M. ulcerans reach the subcutaneous tissue, there's an influx within the first couple of hours of neutrophils to the center of the lesion and MH class II cells to the periphery, followed by sustained recruitment of macrophages for at least a week. Mycobacteria are then phagocytosed and they transiently replicate inside these phagosomes. And then upon replication, the M. ulcerans is released again into the extracellular space, accumulating in a newly formed necrotic area, and then it perpetuates that cycle of mycolactone production. So when it comes to the management, dual antimicrobial combination therapy is recommended, and regimens with an injectable agent are no longer recommended. Routine antimicrobial susceptibility testing is not available in Australia, and primary rifampicin-based regimens are highly effective. So rifampicin at 10 milligrams per kilo per day and clarithromycin 7.5 milligrams per kilogram BD up to a dose of 500 milligrams BD. If rifampicin is contraindicated or not tolerated, then clarithromycin and a fluoroquinolone can be used as well. The duration is 8 weeks for most patients, and a shorter course, I understand, can be considered in patients who are immunocompetent with a small lesion, particularly if they experience adverse effects and had some kind of surgery. And drug-related toxicity does occur in about 20% of patients, so it is significant. Risk factors for treatment failure are increased weight and immunocompromise as well. Most cases are managed non-operatively, but there may be a role sometimes for surgery in certain cases. So surgical debridement to remove the inflammatory stimulus from necrotic tissue in severe paradoxical reactions. Sometimes a narrow excision to shorten the duration of antibiotic duration, like just discussed, and other times a curative wide excision if people have a lot of difficulty with taking antimicrobial therapy, but there is a risk of local or distant relapse, particularly if the histological margins include visible bacteria or active inflammation, if the patient's immunocompromised, or if the lesion has been there for a long time before diagnosis. And wound care is really important as well. That's emphasised in the guidelines. So the 3 stages are cleaning, allowing the wound to heal, and then protecting it from damage. So the really kind of interesting thing, I think, with this infection is the phenomenon of a paradoxical reaction. So about 20% of patients treated with antibiotics will develop a paradoxical reaction, and it's a cause of immune reconstitution. Paradoxical reactions can delay wound healing by 2 months on average, and risk factors for this in Australia are particularly edematous lesions and age over 60. Histopathology often shows intense immune reaction with multinucleated giant cells with few or sparse acid-fast bacilli visible. And paradoxical reactions may be the result of antibiotic-induced suppression of mycolactone synthesis. So upon the initiation of antibiotics, there's often a temporary clinical deterioration with local signs of increasing inflammation, ulceration, and sometimes the development of new lesions. And so steroids can be used in that context, and they don't adversely affect the outcome of antibiotic therapy. So I think it's helpful, like I said, to think about GVHD and how that occurs, because there are really kind of 3 steps to, or 3 kind of contributing factors as to how GVHD comes about. So there's initially the conditioning regimen, so often irradiation and or chemotherapy, which leads to damage and activation of host tissues and induces the secretion of inflammatory cytokines. Then there's the expression of MHC antigens and adhesion molecules is just generally increased, so it enhances recognition of host alloantigens by donor T cells. Then donor T cell activation occurs by interaction with host antigen presenting cells and causes proliferation, differentiation, and secretion of cytokines. The third is really sort of effector functions of mononuclear phagocytes are triggered because of this lipopolysaccharide that leaks through the intestinal mucosa during step 1. So this, I think, we can sort of see the parallels that this response is even further augmented in a patient in whom the immune system is already kind of primed to be super inflammatory. In terms of prevention of Buruli ulcer, so there are things that we can advise patients to do. So mosquito repellent, protective clothing and fly screens in the home, reducing pooled water, so pot plants, wearing gloves and long sleeve shirts and trousers when gardening or working outdoors, and protecting cuts and abrasions with dressings, and also minimising contacts with possums. And currently there are no available vaccines for Buruli ulcer. So back to our case, there are actually no described cases in the literature of an M. ulcerans infection in an allogeneic stem cell recipient that I'm aware of. Essentially the timeline for this patient was he was first reviewed in our clinic in October. The following day, he became febrile and tachycardic, was admitted for investigation, commenced rifampicin and clarithromycin and IV Fluclox for the MSSA that was isolated from his leg as well. So probably had bacterial superinfection. Violet will take us through some of the drug interactions, but his posaconazole was increased to 300 BD whilst he was on that regimen. And his prednisolone was actually increased by hematology and weaned over a course of 3 weeks. During that admission, no alternative source for fever was found. An MRI was done to look for osteomyelitis or deep infection, and neither of those were found. And a PET scan showed diffuse lower limb uptake, but no collection and no other sites of infection, importantly. So at the 8-week mark, it was discharged following that admission, and then at the 8-week mark, we saw him in clinic. He'd had clinical worsening of the ulcer and ongoing fevers. Therapy was continued, and he was being reviewed by HIF for wound management as well. By the 12-week mark, he developed that large wound over his left knee with the central eschar tissue, and still had some ongoing intermittent sweats, but had improved systemically. And by January, he was feeling much better, but the wounds were certainly still there. He had a repeat biopsy which showed necrotic soft tissue, but no active inflammation, granulomas, or malignancy. In fact, they reported that the histological features raised the possibility of an ischemic-like injury. There was no evidence of that, but I think just the severity of the widespread skin changes was kind of reflected by that. AFB smear was negative, but M. ulcerans was still detected on PCR, which I think is not surprising and maybe something that we can talk about. And he completed 17 weeks of antibiotics in early February, and he has remained systemically well. I think he has some ongoing issues with his liver GVHD, but his wounds are stable and gradually, sort of very slowly improving. They're quite healthy wound edges, and he continues to have wound care. So I might hand over there, or I can. Shall we?
Yeah, why don't we just pause for a second? And it's all summarised nicely in one slide, but in fact, this was quite a drawn-out process with a lot of controversial areas. So one thing was he got very unwell and had to be admitted after sort of the diagnosis, and we did put that somewhat down to overarching sort of Staph aureus superinfection as well. So at the time, we chose rifampicin and clarithromycin, and I must say this was, in a lot of discussion with pharmacy and also the hematologist, because we were also trying to balance that with his graft versus host disease, which we can't really monitor very well apart from clinical monitoring. So my first comments, Steve, like rifampicin, clarithromycin is our first line agent. Do we need to think about antimicrobial susceptibility upfront or at somewhere down the track? And bearing in mind that we didn't grow it the first time as well, we just had PCR plus a staph.
Yeah, thanks, Michelle. Really fascinating case, and I just want to say a huge thanks to Nalin for preparing. That's it's really nice to see the work that we've just done on those guidelines presented as well. Hopefully they're useful. I had a couple of comments before I tackle that one, Michelle, but the first one is really about the biopsy not showing any granulomas and whether that's because they're immunocompromised. But in fact, granulomas are often seen at a later stage of Bruley ulcer. They're usually representative of healing, but acute early Bruley ulcer often doesn't have granulomas because of there's so much toxicity from the the high mycolactone concentrations that it may not be seen. I was interested to see the evidence about the acute inflammatory innate process, and that's something that I've also been researching with Catherine Kozerska and their group here at the Doherty Institute. But I'm interested in that because I'm not really sure if it's that believable. I think in the acute inflammatory the acute inflammatory process is mostly a byproduct of the fact that all of our research has been looking at inoculating people with huge doses of the organism, and in reality with mosquitoes being only capable of transmitting a lower number. I think that a lot of that acute inflammation is really just based on our in vivo models, in murine models, etc. So, I'm wondering, something I'm particularly interested in is really exploring that immune interface between M. ulcerans and people. And that paradoxical reaction stuff you talked about as well was really fascinating. And maybe Dan might disagree or agree with me, but in my experience, the paradoxical reaction is really the harder pathology to treat, and often becomes the most challenging aspect because people, they get better and then they get worse again. And if you don't adequately prepare them for that, they often wonder what's going on and they think it's antibiotic failure, etc. But that sort of, I guess the analogy is to leprosy and other cutaneous non-tuberculous mycobacteria, and that you can get paradoxical reactions, and it really prolongs the course of healing. And I can't imagine how long it would take for someone to heal if they had such a profound paradoxical reaction as in this case. We say, I tell patients it might double the time that it takes to heal if they get a significant paradoxical reaction, and something like this, it's a huge delay to their healing process. You made a comment on an ischemic like injury to the whole limb, and one of the features of M. ulcerans is part of its pathophysiology is that it creates a coagulative necrosis and vasculitis within the tissues. So that's not necessarily inconsistent with just the basic way that the mechanism of M. ulcerans and the way that it causes such significant tissue destruction. So that's not super surprising. I was also wondering about all the necrotic tissue and whether there's a role for surgery, and how difficult that discussion would be with such an immunocompromised host. I imagine that's something that has taken up some time. And then to answer your question, Michelle, about susceptibility testing for M. ulcerans, it's not routinely done in a research setting. In fact, I know Maria Globin here at MRL in Vidral is really interested in that topic for NTMs in general. It's something I did. I guess I established a methodology as part of my PhD project. There's really not been much clinical evidence of failure in Australia. To be fair, most of our what appears to be failure ends up being just paradoxical reaction in the absence of anything like patients not taking their antibiotics or having severe intolerances or drug interactions, etc. So it's something that we're definitely interested in doing more of. There's certainly more rifampicin resistant isolates in Africa that have been identified, but it's not something that's been done in Australia. And if given the time and the opportunity and the funding, we'd certainly like to look. And then I guess I was also just wondering if this case is, if the patient's provided consent to write this up and publish it, because it's something that I think we're going to be seeing a lot more of, is these complex immunocompromised people. I challenge the assertion that it's so associated with, water, because now we're seeing it in the inner suburbs of Melbourne and Geelong, where we don't really have water apart from maybe some puddles out the front of our house. And so I think it's becoming clearer and clearer that you don't necessarily have to have that water relationship, but as long as you've got the mosquitoes that are associated with the water, you've probably got the possums and whatever natural host is responsible for transmitting it. You probably have enough to create the environment to transmit M. ulcerans in the community. Sorry, that was just lots of thoughts on what's been presented already, but I'm just really interested and passionate about this subject, so I'll stop.
We can tell, Steve. That's what got you on. Dan, can I ask, for those of us who don't see this often, when you happy that this was a paradoxical reaction, and when would you expect it? Paradoxical means kind of you think it gets better and then gets worse, but in fact, he sort of never truly got better, and whether that was from a staph as well. But I'd love to hear your comments on the case.
Thanks, Michelle, and echo all Steve's comments. And yeah, I mean, it just raises so many. I've got about 50 things here, but so I'm not going to go through them. But I just make the point that, I mean, this case just classically illustrates that it's such an immune-mediated disease. And there's no doubt that people who are immune suppressed get much more severe disease, and it also obviously complicates the treatment, not just from managing the disease itself, but managing all the drug interactions in this certain case where people are on a lot of other medication. And I think we saw this, we're the most experience with this in Africa, where you've got BU HIV co-infection, and they have much more severe disease, bigger lesions, often more than one, and very ulcerated. And then the disease that they tend to get is this nasty edematous or cellulitic disease, is exactly what this person's got. And, it's taken up the whole limb. Now, in my experience, you can put them on antibiotic therapy, but I just often say to patients, the problem is that the damage is already done underneath. And as soon as you get the immune system, and I know he hasn't got a great immune system, but he's got some. And as soon as that starts to be able to work, because you're reversing the mycolactone by killing off the organisms, then you develop an immune reaction, and then you develop paradoxical reactions, which lead to increased tissue necrosis in severe diseases. So a case like this, my experience is that I actually empirically, in this case, increase their immune suppression by giving them prednisolone. And because it's entirely predictable that they will get a paradoxical reaction in such a severe case, and it will lead to significant tissue necrosis. And now it doesn't always prevent it, but in my experience, in severe cases, can conserve some of the tissue and lead to less necrosis. Bearing in mind the disease process hasn't been fixed, so it's often a slow wean, and you've got that issue around things flaring up a bit as you start to wean the steroids, which looks like it happened here. But the thing is that it's almost that's the only way I've learned to try and manage it, because the second you show me that first photo, I know what's going to happen. They're going to lose all the skin off all their leg, regardless of what you treat them, and then you feel bad, they feel bad, and it's a terrible morbidity. And so perhaps steroids can help empirically. So I start them at the same time as the antibiotics. The only other thing I'd say is that there is a mortality with M. ulcerans too. I mean, we don't see it here often in Australia, but again, in that BU HIV cohort in Africa, they have a much higher mortality than if they're not HIV infected alone. And that's because I think they get severe lesions, they get skin sepsis, and as you say here with the staph, they get secondary septicemia. So a case such as this is absolutely life-threatening in a way, and I think that's something that people often don't appreciate about M. ulcerans. That's probably all I'll add at the moment.
Right. That's really very fascinating. Just before we move on, are there any sort of questions about the case? Please pop them in the chat, and we can also have a discussion afterwards. But Abby's got a hand up.
Hi, thanks, Dan and Steve. I guess the one thing we were just looking at in clinic with that really kind of eschar necrotic area was, was there any benefit in trying to debride that at that late stage? Do you have any thoughts on that, or will you just leave that alone and use prednisolone if need be for
No, I would
paroxysmal
normally
reaction?
debride it, definitely, for two reasons. One,
mhm.
I treat the wound just like you would any wound. You know, if it's got necrotic stuff on it, then it's best to remove it. But second of all, that drives the paradoxical reaction as well. So I think for those two reasons, and again, you're just debriding the wound. You're not trying to excise any healthy skin or anything like that. But yeah, I would normally, I mean, smaller areas of eschar and stuff, you can often debride just with, you know, good dressings and an enzymalytic agent that will do it. But in those sorts of ones, I would say, yeah, look, we try and clean it up. So even now, if it's still there, I think it's worth taking off if you can. Yeah. I don't know if
Thanks,
Steve wants to add anything.
Yeah, I agree with you, Dan. Looking at those pictures, it's hard to imagine how that skin's going to be able to heal with so much dead necrotic tissue there. And yeah, as you say, Dan, it drives paradoxical reactions ongoing. So it's probably worth having a chat to the plastic surgeons about even just the most simple superficial debridement. You know, they're not expected to well, one of the issues we have is that, you know, some plastic surgeons aren't super experienced with the debridement required for M. ulcerans. So it might be worth having a chat to some of the team at Royal Melbourne Hospital. I know Arnad Ramakrishnan, who's the director of plastic surgery, has some experience here. And Dan and I have gone and talked at their meetings. But sometimes a junior person might want to come and say, you know, try to debride it like it's a necrotizing fasciitis because it's flesh eating, and so they get, you know, quite anxious. And sometimes you do see kind of paradoxical reactions flare up after significant surgery, but I think it's just impossible for it to heal without just getting rid of some of that dead tissue. Just the most superficial amount of surgery just to get rid of that necrotic eschar.
Right.
Yeah, thanks, Steve. That's really helpful because I think I was kind of keen on doing that, but then, you know, sometimes you worry, have we made, you know, if there are some complications, have we just created a bed for ourselves? But I think it's really helpful to know that, you know, we feel it's going to really help the process along, and so it's strongly justified.
Great. Any further questions? We can sort of talk about it after Violet's presentation. She's going to focus on the drugs and drug-drug interactions. Thank you, Violet.
So much. So yeah, as Michelle said, just a bit of a discussion around the drug interactions and some of the complexities involved, particularly for this case. So just as a way of introduction to drug-drug interactions, so we know that they're often quite challenging, and this is often based in the fact that there's limited PK/PD studies available. So a lot of the decision-making process that is reliant on first principles. So even when there are PK/PD studies available, if there's the absence of these clearly defined concentration to efficacy and toxicity relationships, it can also be difficult to link the clinical implications. But increasingly, medications that are brought to market do include some drug interaction information. So it's just these older medications that we rely on this accumulation of evidence over time. So some of the considerations involved in this process includes both the strength and the number of inhibitors and inducers in these cases, as well as the actual affected drug or the substrate. So what implications does a supratherapeutic or a subtherapeutic level have, as well as is there a prodrug process involved? Are there any active metabolites? And are we able to utilize any therapeutic drug monitoring to help guide some of our decision making? So, but really, I guess important to highlight that a lot of the concurrent enzyme inhibition and induction, as this case, is often an evidence-free zone. So enzyme inhibitors, often have a rapid onset and can have a rapid offset, so long as they're not there's not this irreversible inhibition, and they correlate to the inhibitor concentration, which peaks at steady state. So for the case of clarithromycin, steady state is expected to be around 20 hours. Clarithromycin is a strong CYP3A4/5 and moderate CYP2C19 inhibitor, as well as a PGP inhibitor too. And kind of in contrast, enzyme inducers, the induction occurs a lot slower. So often these upfront dose adjustments may not necessarily be necessary, particularly for critical drugs where therapeutic concentrations are a priority. So if therapeutic drug monitoring is available, we can often use this to guide when we're starting to increase the doses. So rifampicin induces not only CYP enzymes, but has this non-CYP enzyme induction process as well, so through glucuronidases, as is the case with posaconazole, which we'll discuss for this case. But it's a strong inducer for CYP3A4 and CYP2C19, a moderate inducer for CYP1A2, 2B6, 2C8 and 2C9, and a PGP inducer. So linking this back to the case, there's no need for, so from this case, we've got some Bacterium, so no need to worry about the trimethoprim component of this. However, when it's used in combination with the sulfamethoxazole, which is a CYP2C9 substrate, this is going to be induced by rifampicin, but not inhibited by clarithromycin. So there may be a case for dose optimization for treatment, but in prophylaxis, it's not as strong. If there were concerns, though, for PJP infection, there's consideration to change to a 1 tablet daily from a 1 tablet twice a day on the Mondays and Thursdays. Valacyclovir, it's a prodrug for acyclovir, so no need to worry about this process as this prodrug conversion is completed by the hydrolase enzyme and not an enzyme inhibitor. And this enzyme is not inhibited or induced by clarithromycin or rifampicin. The prednisolone, though, as we know, is a little bit trickier. It's a CYP3A4 substrate, so we're likely to see a net increase in the concentrations due to this early immediate CYP inhibition from the clarithromycin, which is quoted to be around 24 to 47%, but then followed by this the introduction of rifampicin, which causes the enzyme induction. So overall, the prednisolone dose, because it's got a relatively wide therapeutic window, and we have a patient who's on PJP prophylaxis, coupled with the overall plan around management to slowly wean the prednisolone over time, dose adjustments can kind of be directed from that regard. And posaconazole and ruxolitinib we'll speak about in the next slides. So posaconazole, it's not metabolized by any CYP enzymes, but rifampicin is still shown to decrease the exposure via this glucuronidation process. So really the key point here is that rifampicin, while we traditionally associate it with these CYP enzymes, we still need to give consideration to these non-CYP substrate drug pathways. And in this case, fortunately, we're able to utilize therapeutic drug monitoring available to guide therapy. Ruxolitinib is a little bit more complex, so it's largely metabolized by CYP3A4, meaning it's likely to be affected by both clarithromycin and rifampicin. So notably, the medication itself is hepatically cleared, whereas the active metabolites are renally cleared. So clarithromycin will increase the exposure of the ruxolitinib by around 91%. So a 50% dose reduction is generally recommended. And this could be considered at least in the early stages before the rifampicin has that induction process start. However, the patient's dose in this case was on the lower end of the spectrum, and when it's being used for myelofibrosis can be dosed up to 20 milligrams twice a day. So to potentially prevent any unnecessary complexity, the dose could be kept the same. And after the 1 to 3 week rifampicin may offset some of the inhibition from the clarithromycin and posaconazole. However, again, it's noted that ruxolitinib has active metabolites. So while the ruxolitinib concentration decreases, there's this concurrent increase in the active metabolites. So there has been a case report in the literature, which was in tuberculosis, looking at the clinical endpoints of patients who were concurrently on ruxolitinib and rifampicin for myelofibrosis. And they reported a clinical success without any dose adjustments, with the theory that the increase in the active metabolite concentration is sufficient enough. So for this case, the patient, sounds like the patient was monitored without any kind of dose changes. So lastly, just wanted to highlight some of the resources available. I think we're quite familiar with this after the COVID era of doing lots of drug interactions, but really the recommendations around using more than one resource to screen for drug interactions. So Stockley's, Lexicomp are kind of the bigger ones. But just wanted to draw everyone's attention to Flockhart table as well, which presents, which is just included in the screenshot below, and it has a lot of that, I guess, really specific information and links to a lot of the evidence surrounding these. If you've got a trickier case where we have all these kind of concurrent inhibition inducer pathways. And that's it. Any questions?
No, thank you, Violet, for that overview. It's very complex. And you're right, we didn't have to specifically dose induce or dose adjust. And speaking of the treatment, I just wanted to get commentary about the duration of treatment. I know we went a little bit longer, and maybe that was nervousness and maybe that wasn't the right thing to do, but in this scenario, immune compromised, extensive sort of lesions, which may all be paradoxical, but duration of treatment. Steve or Dan?
I don't have as much experience as Dan maybe, but I just note that it's pretty uncommon to see such a profoundly immunocompromised patient. There's just very little literature available to guide us. I know that HIV Buruli ulcer kind of co-infection, Dan, you can correct me if I'm wrong, but the World Health Organization doesn't necessarily recommend reducing or prolonging the duration of antibiotics in that context, but it's relatively frequently done for that reason. We just don't have a good proxy for viable organism. Once again, something we're really interested in researching, but because the culture takes such a long time, it's a good question. But I think it's not unreasonable to extend the duration of antibiotics in such a complex patient who's so heavily immunocompromised, because you can't really rely on the immune system to mop up the residual. Dan, you might disagree with me completely, but
no, I was just going to say, what I tend to do is, I know that 8 weeks treatment works for most people, but if they're very immune suppressed and it's a very severe lesion, then I tend to chicken out and go to about 12. I probably wouldn't go much more than 12 in general, and sometimes shorter if people are not tolerating it, for instance, or there's other things. But I think we just don't know, to be honest, and so I tend to go a bit longer than a bit shorter. I think it's difficult there, and as Steve said, we just don't have a proxy for what what you need to get to cure the lesions, because it's clear that everybody has ulcers and everything when they finish their antibiotics. That even a positive culture at the end of treatment doesn't necessarily mean you won't clear the organism. PCR is obviously useless, and the smear is useless as well. So to be honest, it's a bit of a gut feel, and so gaining more and more experience in these sorts of hosts is going to be important. Maybe people will be brave enough to go to 8 weeks and see how it goes. But in general, I must admit, that's what I tend to do. Go a bit longer, as you've done.
Yeah, thanks.
Dan will know. This is a hot topic we've been discussing recently. About using something like culture to sort of give you an idea or a proxy for. Sorry, I should say culture positivity to give you a proxy for duration of treatment, because even in the sort of early trials looking at rifampicin and clarithromycin, some of those patients remained culture positive and yet still healed despite that. So, that's mostly in immunocompetent patients. But yeah, there's so much unknown about this particular topic. It's difficult to know.
And thank you. Just a last question, sort of speaking on behalf of people in the audience who may not know so much about this infection, but can you summarise the thoughts on normally with an ulcer this big, the role of plastics and skin grafting, not necessarily in immune-compromised hosts, but what's the experience, or what have you learnt in previous extensive ulcers?
So again, I just use surgery as a way of wound healing. So if it's a necrotic areas there, then I think debriding them helps. So skin grafting, often large lesions will heal very well with good dressings and time, but it does take time. So it can be, I've had patients who take more than 12 months to heal. I must admit, in really big lesions like that, where you look at it and you think, gosh, this is going to really take a long time, or if it's very painful, some people have really painful ulcers, then I think skin grafting has a real role. But the thing I think you've got to be careful with skin grafting is it has to be done in a delayed fashion, because if you do it too early and there's a lot of mycolactone around still, it will necrose and not take. So I try to wait until antibiotics have actually finished and you feel like you've got a good, clean, hopefully mycolactone-free wound, and then I would recommend it. So plastic surgeons often want to graft, 4 weeks in, 5 weeks, and that almost always fails in my experience.
Right, thank you. Any other questions from the audience whilst we've got everyone on?
I thought an interesting one was, I get asked this all the time, I don't know what Steve thinks, but about the pets, because he had a lot of pets at home,
Yeah.
Can I catch it from my dog or my cat or my alpaca or what else? Now, what we do know is that dogs, cats, alpacas, they can all catch it themselves. So I don't know the answer to that. We did a case-controlled study in the Mornington Peninsula and Bellarine Peninsula. It didn't actually show pets as a risk factor, but you do wonder if they've got it on their nails and they scratch you severely or bite you, whether they could do it. What we do know is possums can transmit it if they're infected, so either through scratches or bites. So I think it's possible, but it's something that I often get asked. I'd be interested to see what Steve thinks. It's certainly not a high risk, I would have thought, and I wouldn't be telling people to get rid of their cats and dogs when they're living in an endemic area and they're immune suppressed, but it's an interesting thing to think about.
Yeah, it's a good question, Dan. My impression is that because so many possums can get clinical disease, they get a high burden of the organism, extracellularly. As Nalin described earlier, the early phases are an intramacrophage kind of growth phase, and then they erupt, and because of the mycolactone, become this heavy burden of extracellular ulcerans, which contaminates the environment. It contaminates mosquitoes. We don't know that method yet, but they seem to be an ultra susceptible host. There seems to be sort of varying degrees of susceptibility in different animal models, and maybe cats, dogs, etc. can get M. ulcerans, but it's pretty uncommon for I've not really heard of vets describing an outbreak of many cats or many dogs, despite the fact that some people have a dozen cats. None of them, it's not something you hear of. Whereas in possums, in some surveys, like you can get a significant proportion of them have active lesions. So it seems to be something about them, ringtails in particular, but also brushtails. It seems to be something very particular about them in my kind of way of thinking about it. Yeah, it's interesting. Makes you wonder why. There's something about them.
Thanks, that's super helpful. We do have another question, like, do different types of mosquitoes, do they have a greater affinity to carry the organism, for example, from work done in Africa versus locally?
Yeah, that's a good question. It's not been identified in the African context like it has here in the Australian context, despite research. So this is the study published late to, or maybe mid last year, PhD study looking at mosquito transmission. It was really Aedes nodoscriptus that was super strongly correlated with the presence of M. ulcerans. So that does seem to be a specific a particular vector of interest, and I know that that's some of the mosquito ecologists are currently doing a lot of study on that. I haven't heard any more since that paper came out last year, but there's definitely a lot of work in that space. I don't know if Dan has any other thoughts.
No, I agree. I think there is some species that are particularly associated, being Aedes nodoscriptus being the big one. It probably does matter, yeah.
Great, wonderful. Sounds like we sort of have a lot more to learn, really. Yeah. If there are no further questions, I just want to really thank Dan and Steve, Nalian and Violet for presenting today. I think we've learned a lot and had some really great discussions about how to handle or manage these difficult cases. So thank you so much.
Thanks, Michelle. Thanks, everyone.
Thanks.
Thanks for having us.
Bye.
See you next week. Bye.